Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today we are joined by Dr. Ray Iezzi, a vitreoretinal surgeon here at Mayo Clinic, for a journal club. We have two fun articles today. The first is a prospective, observational, non-interventional clinical study of the participants with choroideremia, the NIGHT study. And the second is the pros and cons of internal limiting membrane peeling during epiretinal membrane surgery, a randomized clinical trial with microperimetry, or the peeling trial. So we'll talk about the NIGHT study and the peeling trial here today.
Let's kick off the first one. And first of all, thank you for being with us, Dr. Iezzi. You're one of our retinal colleagues here at Mayo, and it helps to not only help to dig through these papers as for audiences that don't have them in front of them, but also just to understand how they apply or don't apply to our clinical practices.
And you're a regular here at the podcast,
Yes.
Your third episode.
Okay.
My pleasure. And these are both very interesting topics for sure.
Yeah. Well, let's talk about the first one. So as Dr. Tooley framed, the first one is a prospective observational non-interventional clinical study of participants with choroideremia, the NIGHT study. And this was written by a large group of investigators led Dr. Robert McLaren et al. It's this NIGHT study group and representative from institutions all over the globe, really, and was published fairly recently in the American Journal of Ophthalmology here in July of 24. So we're looking into choroideremia, and what they did in this study, they randomized males. Obviously, this disease is typically in its fullest manifestation seen in males, and they had adults greater than age 18. We can talk about some of the clinical characteristics, but they had to have, my understanding is, vision impacting visibly active disease. And then they looked at a number of different metrics to assess their current standing, both best corrected visual acuity. They looked at retinal sensitivity, the size of the ellipsoid zone. They did angiography, reading speed. So they looked at other metrics of quantifying vision followed over a 20-month period. And we're going to get to outcomes here, but just share with us just what's the background for this study as you see it, Ray, in terms of how this is helpful or how this frames this disease more than what we already know.
Well, thank you for bringing this paper up. Choroideremia is one of those forms of retinitis pigmentosa that affects males. It's an X-linked disease. Women are affected, but to a lesser extent. And it's also one of those forms of retinitis pigmentosa for which there was a phase 3 clinical trial of an AAV2 associated gene therapy, which was ineffective in meeting its clinical endpoint as defined by the FDA. So that clinical endpoint was number of letters read. Basically, the treatment had to reach 15 letters of improvement relative to the control group. And visual acuity didn't work. And that was the primary outcome measure of that large phase 3 clinical trial. But it's not surprising that it didn't work, because retinitis pigmentosa is primarily a disease of the retinal periphery first, where patients lose rods. And then once all of the rods are lost, then patients start to lose cones. So something about retinitis pigmentosa is clear that rods keep cones alive. And we only see patients with cone loss after all their rods are gone. So for example, if a patient presents with an impairment of visual acuity, just on the eye chart, let's say they're 20/40 and their lens is clear and they don't have any other reason to be 20/40, then before I even look at the visual field or look at the electroretinogram, I know that that patient probably has less than 10 degrees of visual field on the visual field test, and that their ERG shows no rod function, and that their cone function is starting to become impaired, okay? So unless you're enrolling patients who already have a central visual acuity deficit, visual acuity outcomes are not the best outcome measure. And this study aims to figure out, well, what are the best outcome measures? If we're going to offer these novel and innovative treatments to patients with retinitis pigmentosa, and other retinal degenerations, which are exceedingly rare, we certainly don't want to waste anyone's time. We want to know what are the clinical measures that are most relevant. And that's why these natural history studies are so important in these retinal degeneration diseases, because you don't want to apply an improper clinical outcome measure, because ultimately you're not going to fix something that's not fixable or that's not broken, right? In the case of retinitis pigmentosa, we have plenty of patients who are legally blind due to lack of visual field that see 20/20 on the eye chart, and they're going to enjoy 20/20 vision for decades, perhaps. Mm-hmm. So you don't want to use visual acuity as an outcome measure in those patients, because you can't run a clinical trial for decades. So that's why this study was done.
It's really helpful to understand that background. And I want to delve into the background just a tiny bit more and back up a little, because inherited retinal disease, IRD, is a passion of yours. You're an expert at, and you have specific IRD clinics. I remember as a resident being in your clinic and seeing this really special subset of populations with inherited retinal disease. Can you talk us through what your IRD practice is like, what you're seeing RP, how you treat these patients? What makes this patient population different than the kind of traditional retina patient population?
Great question. So when I got here 15 years ago, we set up a dedicated inherited retinal degeneration clinic. And the reason for that was that, first off, there are not many things that we could do at the time. And having a very specialized clinic allowed us to clearly address the patient's visual function, help educate them and inform them on their very rare condition, and help them understand what that condition was and how it affects their vision. Also understanding, how they were functioning at home and at work, if they were working, or at school, and getting them the appropriate services, such as ambulation services or low vision services, so that they can function better. And so that's a population of patients that have rare diseases that often are difficult to understand. They can't talk to their friends about it because no one has it, because it's 1 in maybe 100,000 or 1 in 4,000, depending on how you want to look at it. And so we really needed a clinic where we could spend time with the patient, engage with them, understand how they were doing, and give them the time that they needed. And in putting a patient like that into a high volume, vascular occlusive disease or retinal vascular disease clinic like age-related macular degeneration or diabetic retinopathy clinic, that didn't work. And so dedicating time to those patients was critical. Mm-hmm. And then, of course, we had to get a lot more testing, because we measure how their rods and cones function, how their visual field is working, their acuity, and other things. And many times we even get genetic testing. And we have incorporated our genetics counselors and our medical geneticist, Dr. Lisa Scamenti, into our IRD practice. We've added Dr. Brittany Scruggs, who has a passion for inherited retinal degenerations, and she and I share all of the IRD patients and the practice has expanded. But this is really something that requires dedicated care and attention and a customized treatment plan with specialized testing. So we see a vast array of IRDs, and now that there are several gene therapies being developed for this, we now have interventions. And of course, before there were gene therapies, we were putting in retinal prosthesis to restore vision to patients who've already lost their sight. So this has been an exciting area for many decades to me, because of the idea that we might be able to salvage and regenerate vision.
I think that speaks to, as you mentioned, the unique nature of these centers that are able to best care for these patients in a very unique way, with instrumentation and expertise, genetics included, to provide it. And obviously that's one of the backgrounds for this paper, needing to enlist so many different sites for a rare condition to gather 220 patients. In that, and from your frame of reference, how you track patients in this particular study, they echoed what you shared, which is that best corrected visual acuity was not changed much over a 20-month period. And certainly if we're designing clinical studies to care for patients, that, as you articulated, that isn't the best target or outcome to look for. In the results section of this paper, you comment on all the imaging that you do, and I just like to just reflect on what that might be for a typical patient in your practice. They looked at retinal sensitivity measures, the ellipsoid zone, fundus autofluorescence, also even reading speed here. And across the board, I think that it showed these metrics over a 20-month period, and there was quite some asymmetry between eyes even in this group. That was even though the overall vision didn't change, it was noticeable how one eye tended to be worse than the other, but many of these metrics did decline.
Right.
So curious over what are the common metrics you recommend in caring for a patient like this, and is that a pretty typical clinically understandable way that in a 20-month period there are changes happening even though vision's not
Absolutely.
changing?
Thank you for asking that question. The FDA in the past decade has opened its mind up to metrics of what we call seeing retina. With the advent of OCT, we could now image the photoreceptors. And clearly there's a very clear correlation between the presence of photoreceptors and our performance of visual fields. And we know that retinitis pigmentosa affects the peripheral visual field, but it often doesn't affect visual acuity. And so the classical, 15-letter gain requirement for clinical trials from the FDA had very little relevance. And I think the FDA has woke up to addressing, these other outcome measures. At Mayo, we have a very advanced retinal imaging group. If you're going to look at things in OCTs, like how many photoreceptors does the patient have, you really need computer methods to do a good job of it, because sitting there with calipers on an OCT image and trying to measure the distance of the ellipsoid zone is really not effective. You're in clinic, you're not able as a human to do these measurements in any effective way. And so we're developing machine learning and artificial intelligence programs that can do this for us, so that we can get accurate measurements of how large of a photoreceptor area is still functioning in this patient, how large of a retina pigment epithelial area is still present in this patient, and track those metrics over time. So it's not just a matter of eyeballing the image and saying, yeah, it looks a little bit worse. The fact of the matter is, when you see a patient, and we see our retinitis pigmentosa patients once every 2 years, they're going to have worsening of their disease process every time you see them, unless you're doing some intervention. And we have had improvements. So I don't tend to emphasize to patients, well, your visual field does look worse. I tend to emphasize to patients, how are you doing in your life? And I use their progression as a context, as a backdrop to the kinds of recommendations that I'm going to give those patients. So if they tell me I'm doing great, my job as an accountant is going very well, and I work with spreadsheets all day, I may think back to myself and say, okay, this patient is working with a 10 degree of visual field, and they clearly need their vision for their job. We're going to need to position them so that they're getting the appropriate visual aids that they need. Is their screen, do they have the appropriate IT support? Are they adjusting the size of the monitor, the size of the fonts? Are they magnifying adequately? Is this patient leveraging some of the low vision aids like OrCam, which can read to them or provide other, interpretations of small print? So we try to focus on, leveraging technology to help patients like that. So OCT is very helpful, and we are now using computers to analyze those images. Visual field is also extremely helpful, but many times clinical trialists, particularly from companies, don't want to use psychophysical tests because there's a lot of variance in a visual field, let's say. And when you have an increase in variance, it requires an increase in the enrollment and a lot more costly and a lot more duration of a trial to use something like a psychophysical test that has a high degree of variation. So we use visual fields with the largest size 5 target, which has been shown to have the lowest amount of variance from visit to visit. So those low variances really give us a true idea of what the patient's visual field is doing over time. So I think increasingly we're going to see clinical trials that use quantitative outcome measures and less of the psychophysical testing.
It's certainly palpable that our advancements in inherited retinal disease and the hope for treatments becoming more and more available, understanding the disease progressions like this paper will, sets the backdrop for that and for studying and finding success. So it is an exciting time in retinal diseases.
It really is. I was so happy to see that such a large number ended up leaving the study early to enroll in some of the genetic therapy trials, which were ongoing. And it sounds like that was their hope, that they could get some patients together and say, you're eligible for these other trials, which is super exciting. So that's great.
Sure is.
Yep. Well, we'll move along to our second paper. This is the pros and cons of ILM peeling during ERM surgery. This is the peeling trial using microperimetry. This came out of a large group in mostly France. Jean-Baptiste Decloyer, I think, is the primary author, with my French accent. And so you are an ERM peeling expert, Dr. Iezzi. So talk us through ERM surgery, the concept of ILM peeling versus not, and what this paper was ultimately trying to show.
So it's a great paper. It addresses a question that many vitreoretinal surgeons have had. It's a little bit of an esoteric paper. However, epiretinal membrane surgery is one of the bread and butter procedures that we do all the time. Every time I go to the operating room, I'm dealing with an epiretinal membrane of one form or another. And the management of these patients is a lot more complicated than many folks would admit to. At Mayo Clinic, we've adopted a team-based approach to treating ERM patients. The patient comes in upon referral from a primary ophthalmologist or optometrist with some sort of visual problem. A small subset of patients say, doctor, I don't know why I'm here. I see perfectly fine. And those are the patients that may have a problem with one eye, but their other eye is working very well and their brain is doing a fine job of fusing the two images together. They don't have any issues. They're not closing an eye because it's interfering with their ability to see. And those are patients that in all likelihood don't need any surgery, okay? And so we'll give them an Amsler grid and have them monitor periodically their vision and tell them to come back if they notice any problems reading or seeing or whatnot, and have regular follow-up visits with their referring doctor. Another subset of patients comes in and they'll tell you, when I cover up my right eye, I see distortion and blur, but I see fine with the two eyes open. And we'll take a look at the images and determine if we feel that the vision is going to be progressively declining, and we'll recommend surgery based on either a concern for the long-term health of the retina, or trying to parse out, or are there circumstances where the patient is experiencing problems? Are they experiencing, for example, double vision? And a subset of patients with epiretinal membrane will have double vision. And this is it's often the case that it's a specialized form of double vision called CPR double vision, or central peripheral rivalry, where the peripheries line up. And of course, Eric is an expert at this. The peripheries line up, but the centers don't. And epiretinal membrane surgery, we discovered here at Mayo that epiretinal membrane surgery was a surgical option for the treatment of CPR diplopia. And so a subset of patients in our practice are being operated on to relieve this double vision that they have, which can't be relieved in any other way other than blurring the vision in that eye. And so our approach to surgery there isn't going to be based on a visual acuity outcome. They may be seeing 20/20, but we're offering that surgery to alleviate a double vision problem. And in order to have this double vision, you actually have to be able to see well out of both eyes. And so it's caused us to have to operate on eyes that are progressively better in their vision. And I've modified my surgical technique as a result, because when we peel epiretinal membranes, we can go right for the membrane alone, or we can go for the basement lamina of the Mueller glia, which is the internal limiting membrane upon which these epiretinal membranes grow.
Okay, so this is my question. How easy is it to tell an ERM from an ILM? Is it very obvious? No, of course not. I mean,
So
is there microns thick membranes.
Yeah.
How
So
can
it's
you
a
tell?
great question. Great question. So we can't even resolve the internal limiting lamina on OCT.
Right.
So it's like the thickness
This is a
of the diameter.
make-believe membrane.
That's awesome. It's the thickness of a red blood cell, right? Except we have a tool that we can pull out of our pocket called chromovitrectomy, where we can put ICG down or brilliant blue G
And stain it.
and stain it because the ILM as a basement membrane takes the stain up.
And the ERM doesn't?
That's right.
I see.
And so we could see this baseline staining of the internal limiting lamina and a negative stain where the epiretinal membrane's living.
Or
see.
once you peel the epiretinal membrane, do you reapply the stain to see if the ILM came up or not?
So
Yes.
I see.
Yeah.
Because
Yes.
the essence of this paper was that in some patients it comes up spontaneously.
That's true.
And then in others it doesn't, and then you have to decide to peel or not to
That's
peel.
exactly
To peel or
right.
not to peel.
Sometimes it's really hard to resist the urge to take the ILM because you
course.
see it, it's there. Sometimes there's an edge and it's just sitting there waiting to be
So
peeled.
tempting.
It is so tempting. And there are reasons that we peel it and reasons that we don't peel it. There are those retina specialists that think, well, this is part of the retina. Why would we take this? Because when we peel it, we're actually pulling the end feet off of the Mueller glia. And over time, over a relatively short time, those Mueller glia die. And Mueller glia actually have a role in our vision. They pump out the glutamate. They do a variety of phagocytic functions. They're important in our vision.
glial cells,
They
yeah.
are. They're important in our vision. But we decide to take them when we're trying to peel an epiretinal membrane that we don't want to grow back. Because if we peel the internal limiting lamina, the chances of the epiretinal membrane growing back is very, very low. So we get a very low recurrence rate on ERMs if we take the ILM. And also, a lot of folks were never trained to peel the ERM alone. So just the other day, I was teaching my fellow how to peel an epiretinal membrane without ICG in the eye or even an ILM peel. Sometimes as we peel the epiretinal membrane, because it's fused to the ILM, a portion of the ILM does come up. But I think this paper is addressing, what happens to the vision when we peel the ILM versus when we don't.
Right.
And in our patients with CPR diplopia, they often see really well. And I explained to them that our surgery isn't going to make them see better on the eye chart. It's going to prevent them from having to close one eye to see well from the interference that the fellow eye is giving, and it may correct that double vision. And of course, we work with the orthoptics team and sometimes the strabismus surgeons to deal with any other reasons why a patient might have diplopia after surgery or even before.
And certainly there are plenty that will have an ERM that don't have diplopia too.
For
just
sure.
they're there because they're disrupted by their vision.
Right. And the decision making is different for a patient that's got visual blur. And we have to decide, well, how much is this bothering you? Do you want me to fix that for you or not?
Yep.
And many times we can watch it versus the patients that have double vision.
Yep.
But if a patient's 20/20 and I do an ERM peel, I'm generally not going to peel the internal limiting lamina because their visual acuity will recover much more quickly if I don't peel the ILM.
Well, let's talk about that because that's what this paper.
Yeah, the outcomes are really interesting. Yeah, I mean,
Let's share what this paper addressed then. So, in trying to study that population, they were able to recruit 213 patients. And at the time of peeling the epiretinal membrane, 101, essentially 50% of them, the ILM came with it, which, maybe that's the technique they were using to peel the epiretinal membrane, or maybe they, it just naturally pulled off. 100 of them then, they were able to peel the epiretinal membrane, but the ILM stayed behind with staining, now that we know. And so they made a decision and they randomized those patients, ERM gone, ILM there, whether they should peel the ILM. So 51 got peeled and 50 or 49 did not. And they look back, and in the end, their results would show that what you're saying is true, that of the ones that they peeled, none of them had recurrence of epiretinal membrane.
That's right.
And of the ones that they didn't peel, essentially, I think it was about 20%. Had a recurred epiretinal membrane when they didn't peel the ILM. The long-term visual acuity was the same, but interestingly, going along with what you're just saying in your clinical observation, when you peel the ILM, must be some photoreceptor, some retinal damage, because they talk about two things that it's not in my normal day to talk about: microscotomas and retinal sensitivity. Microscotomas went up, retinal sensitivity went down when they peeled the ILM, and yet it looked like over time those things healed, or much of them did, between the 1 week and 1 month to 6 week as they followed these patients. So in the end, the conclusion was spontaneous ILM peeling is common. Active ILM peeling prevents anatomical ERM recurrence, but may induce retinal impairments and delayed visual recovery. So that was commented. You're feeding right into what their results were. And so talk to us about then. I mean, it seems obvious. Peel it because you don't get an epiretinal membrane back. But talk to us about these microscotoma. What is a microscotoma? How are you picking it up? And how is it relevant for a patient after you peel the ILM?
Great questions. So a microscotoma is a very, very small area where the patient doesn't see so well.
And do they walk in saying, I have microscotoma?
Absolutely
No.
not.
All right.
The patients don't know that this is going on unless they cover one eye and it's a really bad scotoma. But most microscotomas are not symptomatic to the patient, okay? And then the question, of course, is why are they there? I do microperimetry on all my pre and post-op patients. So I modify my surgical technique to minimize any of these changes on the visual field, okay? The fundamental fact is that these epiretinal membranes and ILMs don't just peel themselves. It's a surgeon that goes down onto the neurosensory retina and does things that in some cases could be considered egregious acts. Because, we're taking a forceps, a micro tweezer that's steel, and we're grasping a membrane that's 10 microns thick. And you could potentially grab a fascicle of the nerve fiber layer and crush it. And nerve crush injury is a common model in laboratories to look at cell death. So if you're good, you may not cause as much trauma as if you're maybe a learner or you're having trouble. And so the fact is that there's a heterogeneity of peeling, okay? Because this is delicate stuff, and we're dealing with seeing retina in the center. So it's not a surprise that we're going to see microscotoma develop.
But even in the most talented hands out there, most experienced as vitreoretinal surgeon, when you peel the ILM, even in that setting, it disrupts the retina at some level.
It certainly does.
Okay.
And what I've noticed, and I get a lot of referrals for membrane peeling in patients with glaucoma. What I've noticed is that epiretinal membranes are pretty adherent in glaucoma patients, and it's not uncommon to see progression of their glaucoma after the vitrectomy with membrane peel. So I become very conservative and cautious about offering epiretinal membrane surgery in patients that have glaucoma. Because what I've noticed is that as we're peeling that ILM, let's say, it either comes up like nothing, or we find ourselves with a knife edge fold of the retina because it's super adherent to the retina surface. Okay, and there actually has to be a difference, right? In one case, it's like removing a sticker. It's like removing a Band-Aid.
Yep.
If you got the Band-Aid wet, it can come right off and not pull too much. But if it's, it's a really stuck Band-Aid, then you're going to pull that thing off and it's going to take off a little stratum corneum there, right? And so we don't want, when we're peeling, to pull off that superficial layer of retina, because that's the nerve fiber layer. Those are the ganglion cell layers that let us see. And if it's really adherent, then we might cause a splitting of the retina, a schisis. We could potentially cause some photoreceptor disruption. And in super rare cases, you could unroof the center of the fovea and create a macular hole. And that's not uncommon. I have a saying to my students: the best way to turn a lamellar pseudo-hole, and a lot of folks come in with this idea of a lamellar hole, and that's confusing because it's not really a macular hole, it's a pseudo-hole. The best way to turn a lamellar pseudo-hole into a full-thickness hole is to operate on it, okay? So we don't operate on lamellar pseudo-holes, and that's because of the epiretinal membranes are a different consistency, and they're very adherent to the retina, and it's very easy to open up the fovea. I happen to have the benefit of a microscope-integrated OCT. So in my operations, I use the OCT to verify my anatomical endpoints during surgery. So if for example, we're concerned that I haven't gotten the epiretinal membrane fully, then I'll restain with ICG, let's say, and we'll go back and determine if there's any negative staining. Sometimes we see a splitting of the vitreous, hyaloidal schisis, which can leave remnants back on the retina, and we have to go back and get more membrane. But using the microscope integrated OCT is a big help. And also using that as a quality assurance measure to make sure I haven't opened up the fovea, I haven't created a macular hole during my surgery. So there are risk factors associated with this, and we want to minimize those. And we use pre and post-operative OCT and microperimetry to modify our surgical techniques so that we don't cause too much trauma. But this study showed that over the course of time, things normalized, which is encouraging.
Right. So just like you said, at the 6 month mark, there were significant, at the 1 month mark, there were significant differences between the peeled and not peeled group, where the not peeled group was doing a little bit better. But then everybody reached the same endpoint by 6 and 12 months with no significant differences between the two groups. But again, no recurrence.
Right.
And so is this enough to change clinical practice? Is it still a patient by patient decision? Or is this enough data to say, okay, I'm going to peel everybody?
That's a great question. I think it's really surgeon dependent. Mm-hmm. There are plenty of surgeons that can't peel the ILM because they don't feel comfortable with it. It has a role for sure, especially if you're trying to peel and make sure that you get everything and remove that scaffold for regrowth. Many of these recurrent epiretinal membranes were not clinically relevant. Mm-hmm. So they were using the OCT and they said, oh, there's an epiretinal membrane, but the patients were fine.
Fine, then does
and
it
so
matter?
Does the recurrence of an epiretinal membrane really matter? Only in a small subset of patients, okay? And what we may be observing with these perioperative microscotomata is just a dysfunction of the cells and not a death of them, whereby, they recover to normal function. So maybe it just creates a more prolonged healing. If I take a Band-Aid off that was particularly stuck, I might be razzed for a day or two, right? And so peeling an epiretinal membrane that was particularly adherent could result in some swelling or dysfunction of the cells that then ultimately recover. But I would say that the caveat is that in patients with glaucoma, we have to be very concerned. Many of those patients have adherent membranes that when peeled can lead to progression of their visual field loss. So you have to be very careful.
And so when you say that, is it simply a diagnosis of glaucoma, or are you saying a more advanced glaucoma where we already know their ganglion cell layers impaired, they have dysfunction of visual field already, and peeling, you just don't want to add any added level of microtrauma?
So one fact is that because I do these visual field tests before surgery, a subset of those patients already have split fixation. And even though they're complaining of foveal vision loss, it's not due to the ERM, it's due to their glaucoma affecting the center of their fovea. And so those patients don't get operated on, right? So we're avoiding a negative outcome by explaining that their vision loss can't be corrected with surgery and that it's related to the glaucoma in the first place. The second is for those patients that don't have severe glaucoma, well, I certainly don't want to be the one to accelerate their glaucoma, even if they don't have advanced glaucoma. So I will be much more cautious about operating on a patient with glaucoma. And certainly the advanced glaucoma patients, along with the microperimetry, I do an NFL and GCL analysis on OCT to assess their nerve fiber layer integrity, because I'm going to be pulling on, indirectly pulling on their nerve fiber layer. And I need to know that there's enough cell there that, they're going to be remaining cells when I'm done. So I think that it's an individualized thing. Many times you really have to know that the ERM is in fact causing their symptoms, and it's not a minor thing, it's a major thing. And you have to have anatomical reasons to think that the surgery itself will be safe in those cases.
Well, thank you for coming and explaining not only seeing things that we can't see in terms of the ILM, but also just the complexity behind making decisions to peel or not to peel.
That is the question.
Thank you.
My pleasure.
You can find all episodes of the Mayo Clinic Ophthalmology podcast on our website.
Thank you for listening, and we definitely look forward to sharing more